Hi everyone, I am Dr. Noni. I am writing this article while my wife tells me, please stop playing with your avatar. You are 50 years old for Christ's sake. She may be right. If you still think of the newer Beta-lactams/Beta-lactamase inhibitors mainly as KPC drugs, this paper is the reminder that the story is broader. The message is simple. For some non-KPC multi-drug resistant gram-negatives, these agents can be very useful, but only when you understand the resistance mechanism. Let's go straight to the organisms that matter. First, Burkholderia cepacia complex, especially in cystic fibrosis and other high-risk patients. Everyone. Here, the most clinically relevant signal is ceftazidime-avibactam. Why? Because some Burkholderia resistance is driven by beta-lactamases like PEN-A, PEN-B, and AMP-C, and avibactam can restore activity in at least part of that landscape. The paper reviews in vitro studies showing that adding avibactam can lower ceftazidime MICs, sometimes substantially, and there are several clinical case reports where ceftazidime-avibactam was successfully used, including persistent bacteremia and CF-related infections. But here is the nuance. The data are not uniformly positive. Some studies show meaningful improvement, others are much less impressive. That tells us the effect is probably isolate-dependent and mechanism-dependent. So the clinical takeaway is not ceftazidime-avibactam always works for Burkholderia. The takeaway is, if the isolate tests susceptible, ceftazidime-avibactam is a serious option worth considering. What about meropenem-vaborbactam and imipenem-relebactam for Burkholderia? This review suggests they may have activity in some settings, especially imipenem-relebactam in certain isolates, but the clinical evidence is much thinner. So today for Burkholderia, the name to remember is still ceftazidime-avibactam, with susceptibility data driving the decision. Next, Stenotrophomonas maltophilia. This is probably the most clinically important teaching point in the paper. The authors make a strong case that the traditional comfort with TMP-SMX should be re-examined. Why? Because despite historical first-line status, contemporary pharmacodynamic and microbiologic data show poor bactericidal activity, even against susceptible isolates, and we all know the toxicity profile is not trivial. Mechanistically, Stenotrophomonas carries L1, a metallo-beta-lactamase, and L2, a serine cephalosporinase. That combination is a problem. L1 is not inhibited by currently available BLIs. L2 can be inhibited by agents like avibactam and relebactam. So if you want to beat this organism with beta-lactams, you need a strategy that gets around both. That strategy is aztreonam plus avibactam, previously delivered as aztreonam plus ceftazidime-avibactam. Why this works? Aztreonam survives the metallo-beta-lactamase, and avibactam inhibits L2, protecting aztreonam so it can actually reach the target. That is the mechanistic heart of the paper. And the evidence? The review summarizes multiple in vitro studies showing major MIC reductions with aztreonam-avibactam, plus several clinical case reports where ceftazidime-avibactam plus aztreonam sterilized blood cultures or achieved microbiologic cure in difficult MDR Stenotrophomonas infections. The paper also notes this combination is now one of the preferred approaches in IDSA guidance for MDR Stenotrophomonas. Important caution. Not every case succeeds. The review includes an example of failure in a trial patient and a CF case where symptoms improved but lung function still declined. So this is not magic. But if you want the most practical, high-yield pearl from this paper, it is this. For MDR Stenotrophomonas, think aztreonam-avibactam, or the combination avicaz-aztreonam if in your country, aztreonam-avibactam is not available. Now to Acinetobacter baumannii. Here the message is almost the opposite. The KPC-era BL/BLIs, ceftazidime-avibactam, meropenem-vaborbactam, imipenem-relebactam, generally do not add much for CRAB, because the common carbapenem resistance mechanisms in Acinetobacter are OXA-type enzymes, and these inhibitors do not adequately block the dominant OXA variants like OXA23, OXA24/40, OXA58, and OXA51. So for CRAB, the star here is sulbactam-durlobactam. That is the Acinetobacter-specific story. Sulbactam has intrinsic activity through PBP binding, and durlobactam inhibits relevant class A, C, and D beta-lactamases, including the OXAs that matter in Acinetobacter. In vitro, the susceptibility signal is strong, and in the phase 3 ATTACK trial, sulbactam-durlobactam plus imipenem-cilastatin was non-inferior to colistin plus imipenem-cilastatin for MDRA Bomani calcoaceticus infections with numerically lower 28-day mortality, 19.0% versus 32.3%. That is a major practice-level point. For CRAB, this review reinforces that sulbactam-durlobactam is now the preferred modern move, not recycling the older KPC-targeted BL/BLI mindset. So let me close with the clinical bottom line. 3 organisms, 3 very different lessons. For Burkholderia cepacia complex, think ceftazidime-avibactam, but only with isolate-level susceptibility in mind. For Stenotrophomonas maltophilia, the high-yield combination is aztreonam plus avibactam. For carbapenem-resistant Acinetobacter baumannii, skip the KPC reflex and think sulbactam-durlobactam. That is the real teaching point of this article. Newer BL/BLIs are not one bucket. Their value depends entirely on mechanism. If you know the enzyme, you choose the drug better. And in 2026 ID practice, that is the difference between elegant therapy and noise.